Hello, ladies and gentlemen. Welcome to Triple N Media. I am Dr. Nik Nikam, a cardiologist from Houston, Texas. The feature presentation is Acute Heart Failure. Classes, how do we recognize them, and what do we look for, and how do we treat these patients? So let us begin with the feature presentation. We are quite familiar with the established types of heart failure, namely the systolic heart failure, the diastolic heart failure. However, when patients come to us, that is just one part of their presentation. In addition to having systolic or diastolic dysfunction, there may be a number of other things that may be accounting for the decompensation that we see, which may be related to myocardial ischemia. It can be related to infection. It could be related to renal failure. It could be related to volume overload or any number of things, or pulmonary embolus or bleeding. All of these things can compound the compromised function of the left ventricle to begin with, which results in an acute decompensation. So we're going to look at how do we arrive at a diagnosis of acute decompensation of the heart from a diagnostic perspective and clinical features, and how we tailor our treatment based upon those findings. There could be any number of precipitating factors like infection, ischemia, volume overload, kidney problems. In addition to that, we may have associated volume problems. It could be volume depletion or it could be volume overload. The volume overload could be mainly on the left side of the heart, or the volume overload could be generalized as we see in patients with biventricular failure. So all of these things have to be put together in the context of the patient history, findings, ejection fraction, and of course the lab findings, including the kidney function. So when a patient comes to us, first of all, we need to decide what kind of a decompensation are we dealing with. Is a patient warm and dry? Is a patient warm but he's wet, he's congested, he's got fluid overload? On the other hand, the patient could be cold and dry. All of these things very clearly signify something going on inside the body, which can be easily determined by these peripheral signs like the vital signs, skin temperature, or the urine output, based on things that are very, very simple to measure at bedside. Is a person cold and wet? So what does that mean? So let's look at each one of these categories, because this will help us to triage these patients with heart failure and decide where they go. Do they go home? Do they go to the observation unit? Do they go to the intensive care unit? Or do they go to the cath lab? Or do they need any procedures to support their left ventricular function, which we'll talk about in a minute? If the person is compensated, that means he has adequate pulse and blood pressure. One of the things I forgot to mention was arrhythmias can precipitate acute heart failure, especially in a patient with diastolic dysfunction. If they develop atrial fibrillation, they can go into pulmonary edema in no time. So let's keep in mind cardiac arrhythmias as another major component that can help put patients into a cardiac decompensation. Okay, if the person is warm and dry, that means maybe mildly compromised, but he is, well, more or less compensated because he's got adequate circulation, he's got adequate ventricular function, and these patients may have minor changes in their lab values. There may be some changes in the volume status, but this is something that can be managed with optimizing medical treatment. They don't have ongoing ischemia, no evidence of infection, no evidence of bleeding, and these are the patients who can be managed in a medical outpatient setup. Now let's talk about cold, warm, and wet. The person has adequate circulation, borderline or normal blood pressure, heart rate okay, but this person is volume overloaded. It can be, as I said, biventricular volume overload, or it could be just left-sided heart failure in patients with diastolic dysfunction. So if the person comes to the hospital with this presentation, this patient needs to be admitted. This patient needs to be observed. Does this patient need to go to the ICU? That depends upon, does this patient have unstable hemodynamics or ongoing myocardial ischemia, which may need attention. On the other hand, we have cold and dry. Cold means whenever the extremities are cold, that means the peripheral circulation is poor. When we talk about peripheral circulation being poor, it could be due to low cardiac output, or it could be due to vasoconstriction from any number of causes. So that's something we have to keep in mind, because if a person has fever, they're going to be warm and moist because they have hypercirculation because of the increased temperature. Whereas if a person has a cold and dry appearance, they need to think about volume depletion, bleeding, and low cardiac output state from reduced left ventricular function. On the other hand, if the person is cold and wet, this person is decompensated just like the person who is warm and wet, because these people are volume overloaded. They also have poor perfusion, which may suggest to you for advanced heart failure with significantly reduced ejection fraction, because they are volume overloaded for any number of reasons. Could be kidney problem, medications, or excess salt intake. And as a result, they have excess volume, but they also have significantly compromised left ventricular function. Their ejection fraction may be like 20%, 30%, and that can easily put them into congestive heart failure with volume overload. And these patients need a different approach altogether compared to those who are warm and dry. So just looking at bedside, we should be able to make some decision as to what kind of a patient are we dealing with. Is this person warm, or does this patient have cold extremities? Is this person wet, by signified by increasing shortness of breath, volume overload, increased jugular venous pressure, edema? All these things will put them into this right. Let me see if I can bring my pointer here. Okay, in this category, it is important for us to be clinicians first before we rely on expensive lab tests and x-rays and CAT scans, things like that. Once we have decided what is going on, this person can go home. This person can go to a telemetry unit. The person with a cold and dry who has low cardiac flow state may need inotropes and other supportive measures, volume, and they need to go to the ICU. And same thing with patients who are cold and wet, because they have compromised left ventricular function in addition to either volume depletion or volume overload, depending upon what their situation is. If these patients have cold and dry, then we're talking about inotropes, vasodilators to reduce the systemic vascular resistance, and perhaps maybe an intra-aortic balloon pump if the left ventricular function, I don't know why my mouse keeps, intraventricular function is compromised. Here we use diuretics, vasodilators, and inotropes. Of course, they use the same thing. Let's move on here. And again, this is looking at from a hemodynamic point of view as what is happening inside the heart based on the same triage map we saw in the previous slide. In patients who are warm and dry, they have a normal capillary wedge pressure. Their cardiac index may be normal because they have normal perfusion, and these people are compensated. Whereas here in patients who are cold and dry, their wedge pressure may be normal or low because if they have volume depletion, and their cardiac index may be decreased because of reduced volume, hemorrhage, or reduced systolic function. Whereas here we have elevated pulmonary capillary wedge pressure, and the cardiac index may be normal. Whereas in patients who are cold and wet, who have low, very poor perfusion, we know we are dealing with a far advanced heart failure, patients who have significantly compromised left ventricular function, leading to significantly elevated pulmonary wedge pressures and reduced cardiac index. They also may have increased or normal systemic vascular resistance. So based on these things, these patients who are warm and wet means they need diuretics. They also need something to support their heart function, like an inotrope. Whereas if they are cold and wet, they need vasodilators to improve the peripheral circulation, inotropes to improve their cardiac function, and perhaps diuretics to reduce the venous congestion. If you look at the whole spectrum of patients who come with acute heart failure, about 25% of them fall in the warm, dry category. Majority of them are in the warm, wet. That means they have fairly compensated cardiac function, they have an adequate blood pressure, heart rate, and maybe adequate urine output, but they are volume overloaded for a number of reasons. So these are the patients who would benefit from diuretics, vasodilators, ACE inhibitors, and a fluid restriction. Whereas the cold and dry, it's a hypoperfusion, hypovolemic state. It is exceedingly rare. So that constitute only 5%, and cold and wet about 20%. So if you are dealing with a person who comes in with a congestion, volume overload, that accounts for about 70% of the patients coming with acute heart failure. The main thing you need to differentiate is this person warm or is this person cold? If the person is cold, then you may be looking at reduced cardiac output, reduced cardiac index, and reduced systolic left ventricular function, and that's where the focus needs to be taken. And then you can do an echocardiogram and x-rays to determine their function and then decide what needs to be done. Anyway, so let's move on here. Obviously, we have all these medications, but just having a list of medications is not going to help us as to what medicines we need to use in a given particular patient based upon their profile when they come to the emergency room with acute heart failure. That's why an approach that is more based on the presentation, that points to some of the things that are abnormal in a given patient at that particular moment, then we focus upon how we treat these patients. For example, if they are warm, their normal capillary pressure and cardiac index is normal, maybe minimal decompensation because of slight volume overload, they can be treated with diuretics and followed up in the clinic. There's the mouse. And if they are cold, they definitely are more serious in a more serious situation, so they need to be admitted to the ICU. We need to monitor their hemodynamics. We need to make sure we provide inotropic supports using dobutamine, dopamine, milrinone, along with some vasodilators to improve peripheral circulation. And again, here we talked about diuretics, mainly to get rid of the fluid, because that's the main treatment option available in patients with diastolic heart failure. Because if they develop acute pulmonary edema, they have normal systolic function and their peripheral vascular system is okay. If the kidney function is normal, then they respond usually. Whereas if they have low cardiac output, elevated wedge pressure, low cardiac index, we are talking about systolic heart failure with reduced ejection fraction and poor left ventricular function, which needs a lot of support in terms of vasodilators, inotropes, and perhaps maybe left ventricular assist devices in case of advanced. So ladies and gentlemen, this is a quick overview of how you evaluate a patient at bedside based upon very simple factors like how the patient looks. Is the patient really short of breath or just mildly short of breath or has no shortness of breath? Is the patient volume overloaded? Does the patient look cold and clammy? Is the patient cold and dry? And based on these things, based on the heart rate, blood pressure, urine output, we can make a very quick judgment and triage these patients and get them the appropriate treatment. Thank you so much for watching, and please do subscribe to our YouTube channel. We have ACCHA guidelines starting from 2014 all the way up to 2022. Please do watch them, and I will see you in the next presentation. Thank you.